This abbreviation GERD actually stands for Gastroesophageal Reflux Disorder. The internal circular fibers in the esophagus and the longitudinal fibers of the esophagus at the junction with the stomach, they form a valve-like mechanism. And the purpose of this is the valve dilates, allows the food and the water to get into the stomach, and as the stomach is beginning to operate and grind, this lower esophageal sphincter, it is called LES, tightens and prevents any of this material to be refluxed up into the esophagus. The esophagus, unfortunately, has a different lining than the stomach, and the stomach lining can handle all the pepsin and the gastrin and the acids, but the esophageal, since it does not have that particular lining, it is prone to damage over a period of long term. The difference between GERD and occasional heartburn everybody gets if you have a spicy meal or something, but GERD is actually a pathological differentiation of the mucosa damages, and it is evident when you do upper endoscopy. It's inflamed, it's irritated, and you can also measure the lower esophageal sphincter pressure nowadays much easier with a remote operated capsule called a Bravo capsule. In general, GERD, occasional heartburn is normal, everybody gets it, but when you begin to have at least 3 or 4 times a week symptoms of GERD, which is mostly heartburn and reflux, water brash, and food getting up into the throat, if these symptoms persist, the danger of this is not only the discomfort, but eventually you get inflamed mucosa, which can lead into a precancerous condition called as a Barrett's disease, which can cause adenocarcinoma of the esophagus, or even if you do not get cancer, repeated healing and inflammation of the esophagus can cause esophageal strictures and difficulty swallowing, which is called dysphagia. The most common risk factors appears to be anything that decreases the lower esophageal sphincter pressure, such as caffeine, smoking, excess amount of alcohol, obesity, and not paying attention to your food intake, to take smaller quantities of food over a period of time rather than 1 or 2 big meals. And especially if you have a big meal, it takes 3 hours for the stomach to empty, and in that period of time, if you lie down, the reclined position, all this material is going to be pushed against the esophageal valve and predisposes you to develop a lower esophageal sphincter weakness and eventually GERD. To prevent GERD, some of it is genetic. It's difficult to stop it completely because some people are born with lower esophageal sphincter pressures. They are obviously more prone, but most of the people are developed as we age. Age itself is a process of lowering esophageal sphincter, which nothing we can avoid about it. Definitely obesity will be a factor to consider. Stop irritating substances, excess amount of spicy food, especially smoking, and nicotine in any form, chewing tobacco or one of those, alcohol, and lack of exercise, and going to bed too early after eating. The prevention of the GERD symptoms to exaggeration is to avoid all the substances we talked about, which increase the acid load for the stomach and decrease the lower esophageal sphincter, and to attempt at least a 10% to 15% weight loss if they have obesity, and modify your lifestyle as far as going to bed at early time, give 3 hours after you eat before you lie down at night time, will be the ones to protect you from future GERD. The treatment, in spite of taking all these precautions we mentioned before, still eventually some of the patients will continue to be bothered with symptoms of heartburn and GERD. So for those, there is medications which will be helpful. Most of the medications deal with the excess production of the acid. So these are 2 quality of medications are available. One is called the H2 blockers, which are milder type of medications which suppress the acid production. So we have only Pepsid at this time, which is over the counter, which certainly can be tried by the patient. And if there is no resolution of the symptoms, he may approach the physician. They may be starting them on proton pump inhibitors called PPIs. They are such as omeprazole and pantoprazole. These medicines, they start at a higher dose initially to suppress the inflammation in the esophagus, like pantoprazole 40 milligrams twice daily for 3 to 4 weeks. After the symptoms are suppressed, maybe attempt to a single day dose, and then eventually maybe tried on 20 milligrams, which will be a continuous long-term dosage. There are surgical interventions. The first thing to do would be do an upper endoscopy, which will quantify the kind of reflux that you have and the grade of the reflux you have. And also it will determine whether you have a sliding type of hiatal hernia, where the mucosa of the gastric lining is refluxing up into the esophagus. This now becomes a mechanical problem, so no amount of medications alone might help the patient. So there are endoscopic procedures which can restrict the movement of the gastric lining into the esophagus, such called as funduplication, which can be done without cutting through the endoscope itself. GERD can be cured with excellent endoscopic surgical procedures, and if these fail, sometimes people do have also paraesophageal hernias which may be contributing to the reflux. Those cannot be successfully operated through endoscopically. They will have to be done abdominal approach or thoracic approach through a laparoscopic procedure, and they will get 90% relief of the GERD.